You're listening to Health Tech Matters, a podcast brought to you by the Pankhurst Institute at the University of Manchester. I'm your host, Lamiece Hassan.
In the next episode, we'll be joined by Dr Claudia Lindner.
So yes, I agree it will reshape their jobs. I don't think it would take away any jobs. I think it's really about making the most or benefiting the most from combining what a computer can do with the expertise and the skills of the clinician.
We talk about the role of AI in analysing medical images, such as X-rays. And I'm really excited to hear about how AI is going to change the way we deliver clinical services and bring benefits to patients.
Hi Claudia, thanks for joining us today. Obviously, we've known each other for quite a while now. We were on that previous fellowship scheme with Health Data Research UK, but we haven't had a chance to catch up for ages, so I've really been looking forward to this.
Hi Lamiece, good to see you again.
So you've recently won, I'll get this right, a Sir Henry Dale Fellowship from the Wellcome Trust and Royal Society. Congratulations.
Thank you.
As I understand it, this is all about developing software to automatically analyse medical images and other data to improve care for people who are having knee surgery. Is that correct?
Yes, that's right.
Can you tell us a bit about your plans and what's involved in the fellowship?
Okay, so the project actually got two components. So the medical imaging part is looking at both at images and other data, as you said, clinical data, but also patient-reported outcomes data, both preoperative, so that is before patient go into surgery, but also postoperative. And there are two main reasons for that. Preoperatively, it's because research has identified there's about 20% of patients which unfortunately, even after surgery, still suffer from knee pain. So for these patients, maybe the surgery wasn't the best choice of treatment, or maybe not at that point in time. And so there might be other intervention that could be happening either before surgery or instead of surgery. So it's about looking into whether we can identify those patients to then make better treatment decisions. And so the second part is to look at patients who already have had surgery. And there it's into looking whether we can identify patients where the implant is failing early. So for a lot of patients, those implants nowadays last 20, 25 years. But there are some patients where unfortunately this isn't the case and the implant might fail after 5 years or after 10 years. And sometimes patients only get to see their clinicians when they feel a lot of pain again to the clinics. And that's where unfortunately from a bone point of view, a lot of bone has already been destroyed. And so it's about identifying these patients early so that we can track them more closely, so that we identify a failing implant early on. And at the same time, it also means that there might be other patients who do perfectly well for 25 years, and there's no need to see them every 1 or every 5 years and have another clinical appointments to have more x-rays given. So it's really about stratifying whether we can identify people that are doing well and they're likely not to do so well. So that's the medical imaging part that you mentioned. The other part of the project is the translational part. And so it's about looking at that whole pathway, what's happening at research level, and then how can we take these things, or how can we encourage people to take these things into the clinics?
Wow, okay, so that's a lot to unpack there. So are we talking about patients who've got something like arthritis, perhaps?
Yes, so in terms of knee replacements, the majority, I think it's about 96% of people that do have a knee replacement will have some form of arthritis, yes.
Okay, so you've made a convincing case for why we need to look at these patients and why this kind of work could be important. Could you tell us a little bit about what your actual research might involve?
Okay, so for the medical imaging part, in terms of techniques, it's what's called computer vision. So that's about how can you tell the computer to look at an image and to derive information from the images. So maybe able to quantify what's in the images, to measure what's in the images, but also to identify patterns in the images. And that's where we would use techniques from machine learning, which nowadays is often referred to as AI. But yeah, it's methods from machine learning and data science.
I was going to ask you this actually. Do you regard yourself as a data scientist? Is that a label you associate with?
I think I've got all kind of labels, probably, I would say, yeah. So data science is one of them.
I'm sure you've heard data science being described as one of the sexiest jobs of the 21st century. Maybe I wouldn't give it that label, but I'm curious to hear your experience of what it's like on a day-to-day. So could you tell us a bit about what a typical workday might look for you when you're using these kind of techniques?
I guess, and I also would say there isn't a typical workday. It varies from day to day, which is why I really enjoy what I'm doing, because it's so varied and no day is the same. In terms of workdays, I think the constants are emails and meetings, which are there every single day. But the type of emails and the type of meetings vary. So it might be involving clinicians, it might be involving industry partners, it might be involving patients, it might be involving staff, student. And then there's also obviously the research bit, which again's got quite a few different components. So you could take the data analysis side of things or the machine learning side of things. So that's about using machine learning techniques to teach the computer, I was mentioning earlier, to extract information from the images. But then you need to assess that whatever you developed is actually working, and that's where the data analysis and the data science bit really is coming in terms of assessing, is the system doing what you expect it to do to sufficient accuracy. But then you want to get your results out there as well. So another point is communication. So communication that could be around publications at conferences, writing papers, but it could also be in terms of patient and public engagement and getting a message out there to the public in terms of the research that you're doing. So there's lots of different components, really.
That's great. It sounds really varied what you're doing and not completely unfamiliar to me either. I'm used to working with pretty large data sets like social media, wearables data, records data, but imaging data, that sounds like something that could be quite computationally intensive, that takes up a lot of resources. How is it working with imaging data in particular?
I've been in the medical imaging field for quite a few years now, so I'm quite used to images. I do have to say, so the imaging data I'm working with is mainly just what's called plain film. So it's not 3D data, it's just 2D data. So the data itself is not as big. I think another difference though is the data set size, which in some areas can be easier to achieve than in imaging. So what I mean by that, in the field of computer vision, people always they might work on images of faces, of cars, etc. And if you harvest the internet, you get lots of these. And there's lots of AI technologies developed using this. But if you go into the medical field, it's a lot more difficult to get large data sets. Because ideally you want to get the data sets out of the clinics, and that can be quite troublesome to try to get access to that data.
Okay, so thanks. That gives us a bit of an insight into some of the technical aspects of your work. Can you tell us a bit about how this project builds on your previous work? Like, I'm sure you've mentioned Bone Finder. People might be familiar with that if they're familiar with your work.
Yeah, so in terms of the technology for the medical imaging part, it is very much based on the Bone Finder technology. So for those who have not heard of Bone Finder, it's a machine learning based technology to basically automatically find structures in images. So my work focuses a lot on musculoskeletal images. So these are x-rays of different parts of the bodies, maybe showing knees or hips or hands or feet. And so the Bone Finder technology allows you to, for example, outline that structure in those images. But it goes beyond that. It's not just about outline. It's also about what I call feature point detection. So it can localize specific points of interests that might be present across the images. So if you think, for example, about your hand, and you might want to identify specific finger joints, and you might want to place a point at different finger joints, and the technology will allow you to locate these. And so in this fellowship project, I will use this technology and apply it to images of the knee. And as mentioned before, so that will be preoperative images. So these are just images of the bones, but it will also include the postoperative images, which then, in addition to the bones, include implants. So it's a lot also about identifying where is the implant, how's the implant being placed, has the implant maybe become loose for the bone, and to identify what's going on in the texture on these images to try to identify any problems.
So if I get this straight, could this be done in like a live setting? So someone working out where, like within surgery, or is it more about checking about how something is done after surgery or before surgery, in a kind of more of a static sense, or monitoring and follow-up?
Yeah, so it's more about after surgery and before surgery to assess it. But in terms of linking it to the surgery, one aspect of the project is also to look into develop a training tool for surgeons. And so that is about providing feedback to surgeons on how well they've actually put the implant in. So currently they don't really get that feedback until quite late, until they might have heard, oh, this patient didn't do well 5 years later, and so maybe it wasn't put in right at the beginning. And so the idea is if we can give in particular unexperienced surgeons that's just starting the journey into this profession, some early feedback in terms of how well did the surgery go with putting the implant in, then there's evidence that this will improve their learning curve quite significantly to improve putting the implant in correctly.
I think that's a really interesting point you picked up on there, how AI could actually support surgeons and healthcare professionals more generally to improve aspects of their job. A common concern amongst people is that increasing use of AI might actually reshape job roles or even replace certain roles. Do radiographers out of their job, for example? That's something I've heard. How likely is that, do you think?
I certainly would agree with reshaping. I wouldn't agree with replacing. And obviously there are different clinical professions, in particular in the radiologist space. That certainly has been a concern from a lot of the community in terms of, AI and computers are taking away our jobs. But the clinical society in that space has been very active for quite a few years now, trying to demystify that and clarifying, no, it's not about taking away jobs. It's about taking over activities that maybe a machine can do and that you don't need to do. So you've got the time to focus on other things. So yes, I agree it will reshape their jobs. I don't think it would take away any jobs. I think it's really about making the most or benefiting the most from combining what a computer can do with the expertise and the skills of the clinician.
Thank you. That's interesting. I'm sure reassuring for lots of people, especially people like students thinking about what options they might want to take on, and hopefully won't be steering away people from choosing radiography, and they'll look at AI as more of an exciting opportunity that can actually blend and improve their practice rather than a threat.
I think what you find there that, certainly from my experience, that the younger generation is a lot more open to it. So some of the clinical collaborators that have approached me in the past were mainly from the what I would call the younger generation, who are really open, who understand of AI and how it works, to be able to incorporate it into what they're doing. And so they seem to be quite keen to take that into account and wanting to know a bit more about it so that they can do a better job. But again, I think it's about the training that the clinical communities and the clinical societies are offering. So again, in the radiologist space, there's AI skills training is now part of their curriculum in some places, where there might be other clinical areas of expertise where this isn't the case yet. So I think going forward, it's probably quite important for any professional training in the clinical space to at least provide some skills development in the digital space so that the workforce can be prepared for what is coming.
Yeah, that's such a good point. That idea of integrating digital skills at different levels is something I'm really passionate about. We actually recently completed a project with Health Education England looking at competencies for different levels of staff. Just before we move on from talking about your project and to your other exciting roles, is there anything in your projects or in the near future that you're really excited about doing or learning that people might want to look out for, perhaps?
There are quite a few exciting ones. Maybe two to highlight is, one bit is the data that we've got available for this project. So we're in the fortunate position that we've got quite a large data set. So as part of my previous HDR UK fellowship, we collected over 18,000 images from people who have had knee replacement surgery together with the clinical data and also patient-reported outcomes data. And so in the orthopedic space, this is quite a unique data set to be so large, just because it's so difficult to get that data. So it's really quite exciting to start to look into this data and to see what pattern we can identify once we're analyzing the data. And so the other bit I'd like to highlight in terms of what's exciting is that going beyond analyzing what is the images, the project also includes to look at clinical pathways. So we're going to do some qualitative work in terms of identifying how are decisions around knee replacements currently being made and how different clinicians at different trusts and at different levels of expertise make decisions together with the patient to whether to operate or not to operate and when to operate. And so this is quite exciting. It's also a new field, so I'm currently attending some training in qualitative research to take this further. But yeah, it's quite exciting to do that space as well.
Oh, wow, that's quite a leap.
Yes.
Yeah, okay, well, we wish you well with that.
This podcast is brought to you by the Christabel Pankhurst Institute at the University of Manchester. At the Institute, we explore solutions to healthcare challenges by translating research into practice. We love to collaborate, so if you have an idea or would like to come on the podcast, please get in touch.
Okay, so when I was preparing for this interview, one of the other things I noticed about you, a little bit envious of, if I'm honest as well, is that you've had the opportunity to work on health technology projects all over the world. So places like Germany, your home country?
It is, yes.
Australia and also the UK. Can you tell us a little bit about how the research culture in the UK compares to other places that you've worked in the world? Do you think there's anything we can learn from them or vice versa?
I think one aspect to pick out here is the attitude towards well-being. So when I moved to Australia from Germany, I was quite in a bit of a positive shock, I would say, in terms of the working environment. So I was used to work being all about outcomes. You got to focus on your work, you got to achieve outcomes. And when I was working in Australia, it was all about you. So there was a focus on you enjoying your job and you wanting to stay in your job and, well-being and your health put first. And for me, it was just a very different climate. And it took me quite a while to get used to that idea and to accept it in a way. But it's also something I got used to enjoying, I think, which is really quite important. And it's not just about well-being, but it's also about teamwork and team spirit and getting people together. So there's a lot of focus in Australia to actively support that outside of the working environment, just so that teams get to know each other and work better together in the working environment. And so what I found is that from personal experience, the UK is somewhere in the middle between Germany and Australia. So I quite enjoy that. I think, unfortunately, the last couple of years with everything that happened here and everywhere in the world didn't really help in terms of people being able necessarily to focus on their well-being and to have a good team spirit, because the circumstances just made it really difficult to achieve that. And I don't think that's just the case in higher education. I think that's a case across different professions, really. So I think it's even more important to actively focus on that and to do initiatives to support well-being, to support team spirit.
I think what you're saying about teams working together is something that resonates with me, but it's also been picked up by several of the guests that we've had on the podcast, because it seems strange that we're often judged individually on projects, yet so much of our research is done in teams. I don't think I've ever written a paper that hasn't included at least one other co-author. So it seems to me that fostering that team environment is something that's really important. And it sounds like there's a lot we can learn from places like Australia then in that sense. It's
a bit about actively creating it and not just leaving it to chance for it to happen. So, I remember one of the job roles I had, we went out to a golf course one Friday afternoon, and it was part of work. Obviously, it wasn't work, it was playing golf. But it just helped to get people together and to get that team spirit and for people to trust each other, so that then in the working environment, you knew who you were working with.
Were you any good?
No.
Oh never mind, but hopefully you got to know people. I always wondered, is the NHS special in any way when it comes to doing research, given what you know from working in other countries? Or is it the same everywhere? There's the same challenges in trying to get technology and research into practice in healthcare?
I think what's great about the NHS is the amount of digital data that is being collected. So compared to some other countries, it's very digitized already. So we've got digital health records, we've got digital prescriptions, we've got digital images being saved in imaging servers. So all of the data is being digitally collected. And I think that's a real benefit. From a researcher point of view, there's a bit of frustration in the sense that it's really hard to get access to that data. So, going forward, that's one thing I would wish for just to be a bit easier to access, in particular, anonymized data for research purposes. So, for example, in my project, I'm looking at knee x-rays. So no one will be able to identify someone from an image of their knee. Nevertheless, it just goes through a lot of hoops and hoops and hoops for us to be able to look at these anonymized x-rays. And so that's a frustration part. So the data's there, which is fantastic. I think we just need to make the access to that data for the research community a tiny bit easier and a bit faster, so that the research can be accelerated, and that way the patient can benefit quicker from it as well.
Great. So some proportionality between that focus between privacy and actually thinking about the benefits. Lastly, before we sign off, can I ask you what led you to settle in Manchester, other than our fabulous weather?
I actually like the weather. So I came to Manchester to do my PhD. That was at the time when I decided I wanted to do a PhD. So I had opportunities before, but I kind of felt the pressure like I should do a PhD because I've got the opportunity to. So I actually took some time out, and that's, for example, when I went to Australia, to think about what I actually want. And so I made the decision, I want to do a PhD. I want to do it in medical imaging because I find that very personally motivating to do something where you can have an actual impact on the life of people. And so there was an interesting interdisciplinary project coming up here at the university in Manchester, and which included funding for EU students, which is what I needed at that point in time. And so I applied for it, and I was invited for interview. And the interview took place on a Friday, I remember. And because it was such a short notice, flight prices were just ridiculous. So because of that, I actually had to stay for the weekend to make the return flight affordable. And so I loved it. So I spent my weekend in Manchester and absolutely loved it. I was like, yeah, I had a great time. And I was hoping to get the PhD position. I did get the PhD position, and more than 12 years later, I'm still here.
I'm sure Manchester's very glad to have you. Claudia, it's been a pleasure talking to you today. I really look forward to following your progress with your new project and hearing about, in future, all the great things I'm sure you're going to do. Thank you so much for your time.
Thank you very much, Lamiece.
In the next episode, we talk about team science and the importance of interdisciplinary working when developing new health technologies. We're joined by Ruth Norris and Charlie Stockton-Powdrell. This is going to be a really fun conversation, so I hope you can join us.